whilst you're doing that, may I start anyway?
Please.
I want to start by suggesting you can't look at China in isolation. Healthcare is something that has to be looked at in the round. We British can be extremely arrogant about the NHS. We say it's the greatest thing, and the politicians at the moment, as we're noticing, it's a political football that gets beaten around. But also, there is a great deal of research now going on by NHS England. And this differentiates it from everywhere else in the UK, which I find slightly strange. I once went to America and I arrived at New York and they said, "What nationality are you?" And I said, "I'm English." They said, "There's no such thing, it's a language." And when I said, "But you have Scottish here, Irish?" And she said, "Yes, yes." No, English. And they wouldn't allow me in until I said I was British, so I actually had to say I was British. But this is NHS England that made this piece, that is doing this research on what healthcare needs to do and how it needs to change. The second thing I wanted to say is, a girl from Goldman Sachs, one day a Chinese girl from Goldman Sachs was giving a talk here in England, in London, and she said, "You think of China as the wealthiest or the second wealthiest country in the world." Yes, we all said. "We think ourselves as a poor country because we think of ourselves as GDP per capita, and in that respect we're 121st in the world." So that dilemma is something we also have to take into account. So the first thing I want to say is the NHS is undergoing changes here in the UK. We are saying that we need to dissolve the traditional boundaries between the GPs, primary care and secondary care. We have a system which is demarcated in a way which is extremely difficult for people to use it. It's a process-driven service. And this is something that we are having to look at. And also we have the most intensive, focused care system pretty well in the world. We have more centralized hospitals, and I'm looking now at a university city which has 4 hospitals, and they're looking at reducing the acute care operations down to 1. I think this is the wrong way of travel, but this is something we're going to be picking up with them, but it's something that's going on here. So, if you can move to the next slide. So we have to look at the differences in order to understand how we can help and how we can work together. And the most critical thing is, look, the most important thing to look at is this one. China spends 1/10 of what we spend on healthcare, and we are struggling with our budgets, so how much more must they be struggling with theirs is the question one sort of naturally asks oneself. Thank you. The other thing is to notice the difference between the public sectors and the private sectors between the two countries. The British private sector has always been, I think when I started it was 14%, and it's now gone up to 17.5%, and that's in work years. So I'm not going to tell you how long, but that's in very many years. It really hasn't changed that much. The other problem, which all of you may or may not understand, is that the British private hospitals and the nursing home groups have been severely challenged by the way they're financed. In the UK, the private equity funds have taken over, so the hospital group that I used to work for many years ago, General Healthcare Group, BMI, now has got an enormous debt burden around its neck. It has been owned by 4 private equity funds since 1994, and it is struggling a lot to try and find its way to build, because the growth just hasn't happened, as this shows here. If that's only gone from 14% to 17.5%, really the growth of the market hasn't happened. So if we go to the next slide. But we have much in common with China. Healthcare is changing. The demographics is changing. The aging population in China, wow, it's dramatic. I think the date was 2042, there's going to be 430 million people over the age of 65. It's a huge burden for the economy. Or it's not. And that's the point we have to try to look at. Epidemiology. the huge increase in non-communicable diseases, 95 million cases of diabetes, but worse, 140 million who will get it if they don't change their lifestyle. So this is one of the things that's important for us to understand. What is very important for me to know, and why I like working in China and why I like working in other developing countries in which I work, Thailand and ASEAN countries and so forth, is that China has been talking about prevention now for 5 years. It has been talking about integration for 5 years. It's been talking about continuing care for 5 years. Britain today is talking about integration as if it's a thing they've just invented. So it is very interesting for us working in these countries that we have a lot to learn from them, and then we got a lot to bring back to ourselves here in this country. The opportunity to use technology, lots of potential, but it needs to be joined up. The problem is that if you go to Imperial College, for example, you'll see some of the most fantastic ideas that have been developed, but they're developed as single ideas. They don't often see how they can apply in an integrated way on a platform which allows them to be used in a proper functional way. Next slide. I brought this elephant and brought him into the room just to show you that affordability is the biggest problem that we have here, and it's the biggest problem that we have in China. Next slide, please. So that was a figure, 438 by 2042. Lifestyle is changing, epidemiological, age trends and so forth, the prevention, integrated care, and now we need affordability. Now, integrated care means joined up care. It means looking at people from the point of view of whether they need real treatment in the case of hospital treatment, or whether they need care in the case of social care. In this country, as you probably read 2 weeks ago or 3 weeks ago, the government suggested that Manchester should control its own NHS budget so that it could tie its NHS budget with its social care budget to create that integrated care. That is something that is necessary also in China. The trouble in China is that social services are not very well developed because they are complicated for the government to provide, because if you go too far, they transfer responsibility from family to the state, and the state is terrified of such a responsibility. As we are here, we're pretty frightened about it, but we're a democracy. They have less of a mandate to be able to do that sort of thing, and therefore it is a responsibility they'd rather avoid. As a result, when you look at community care, it is very much more private and family orientated, and the family is responsible for looking after their own. The rule that the Chinese say, or it's not the rule, the standard that they say, they call it 97-3. 90% of families look after their own, 7% of elderly people go into nursing homes by the state, and 3% go into nursing homes by the private sector. And normally when it happens, the family is embarrassed and does not wish to acknowledge that their family is in a nursing home. The other thing which is important is the problem we have in this country, which is mobility of labor. The mobility of labor is creating a pressure on the family, so that the traditional family, which is a three-generation family, the middle generation, which is the main working component of the family, is sometimes having to move to other cities, and even as we see here in England, to other countries, in order to earn the money they need. And this is dividing the family and creating problems. May I have the next slide? We are developing what we call an integrated care model. So the outer circle is the healthy circle. It's where we should live, where we want to be living. And what happens, we look after ourselves, but we have periodic assessment and so on. Now, one of the things that's been referred to twice today is primary care and secondary care. And one of the pieces of research that Glasgow University came up with, I remember you telling me, was that if more people use primary care, it would free up their hospitals to a level of 40% of their utilization. I think that was the figures. However, we have to understand that it's not just in China, but in many countries. I first encountered this in Iran. If a doctor is sent out, or if a doctor works out in the community, he is considered either to be a failed doctor, or he gets lost in the system and he never gets back. And the Iranians had to solve this problem by creating a national service system where the doctors had to do 2 years out of the cities, and then they could come back because they were on a hook to bring them back in. In China, the big problem is similar. They do not think that a doctor who doesn't work in a hospital is as good as a doctor who does work in a hospital. This is it's a challenge. But sometimes you have to accept that. If we look at primary care in this country, it costs 26% of our GDP, of our NHS budget. If you extrapolated that for China, it would cost 48% of the budget. It would utilize over 50% of the doctors. It would make the whole system collapse. So we have to find different techniques. And the techniques that can be found, one technique is using technology more effectively. The other one, to which Douglas was referring to, was the fact that pharmaceuticals are bought 70% in the hospitals, but part of the reason for that is the pharmacists in the pharmacies are just not well enough trained. I personally find it quite often better to go to a pharmacist than to go to my GP when I have something that's wrong with me. You can't yet do that in China. You can in Hong Kong, but there are very few. Most pharmacies in China are just retail pharmacies. They do not have very much expertise in formulations and so on. Now, if that could be changed, I think that's another area which it would be a very good thing to be looking at. So if we look at this for a moment, the system is this. So you have an assessment. You're brought down, and somebody says, okay, the system says, it could be internet system, says you need to be checked. So you come down into what we call the amber zone, and a primary care situation of some sort. Again, this is a model that the NHS is now looking at, is to go back to something which is different but similar to what we've done many years before, which is to bring primary care to front of house of hospitals, not in hospitals, but front of house. What we used to call in Central Europe, we used to call filter clinics. Bring it to the front of the house of the hospital, thereby you have the relationship between the hospital and the primary care much more easily resolved. And we decide what's matter, and then if nothing matter, they go back. And if something is the matter and they need to be referred to the hospital setting, they can be referred to the hospital setting. Now this system, we developed this, I think originally I developed this with Samsung, when Samsung asked us to look at some work in Shanghai. Unfortunately, they told me they wanted to build a hospital in Shanghai. What they really wanted to do was a piece of research. The research was to find out whether they had within their company the critical mass to be a hospital developer. And that's why they wanted me to do the work, and we did this work for them. And in the end, they said they didn't have the critical mass. Now, as an aside, I am now working in Thailand, and I have Hitachi as my technology partner there, or our technology partner. And they do have the critical mass. They can provide 40% of whatever a hospital needs for the development of a hospital within their own company, which means they're very interested in integrating out of 900 companies they have, the various companies that can provide lifts, plant, air conditioning systems, power, medical equipment, and even information technology. Can I have the next slide, please? The next thing to say is we keep talking about we need to look at elderly care. As I get older, I keep thinking to myself, I'm a person. I'm still the same person that I used to be. Please stop telling me that I'm an old person. I'm just a person. And one of the tragedies that we've had in this country is that we have put elderly people into nursing homes where the most exciting thing they see all day long is a robin pulling a worm out of the ground. We need to have something where they can engage with people and people can engage with them. Again, in Thailand at the university that I'm working with, the Japanese government have asked us to take 350 Japanese elderly people and have them on the campus of the university so that they can engage with the students and the students can engage with them, and they look and talk and help each other, and suddenly both of them are more useful. And if we've got this vast number of elderly people, we need them to be more useful, and therefore we need them to be more integrated into the system. So what you need to do is increase the support for people and make that support as cost effective as possible. If we move to the next slide, please. We were working on what we called a lifestyle development in Chongqing. And I love Chongqing, but it used to be described as the biggest place, the biggest city in the world that nobody's ever heard of. But I found out about it and I enjoy it very much. They have their own patois called Chongqingese, which I couldn't possibly talk about. I can't be Mandarin either, but they're a delightful people. What we had here was, this was an area of 1,000 mu, which was that's 667,000 square meters. And within this, we created a small community, which was part of a wider community. So this was about, because it's very intensely developed, it had what was called a floor area ratio, FAR, of 2.4. So we were having up to 35,000 people in this relatively small area. And it was part of an area which had 210,000. And that was part of another area which was 1.75 million, which was part of another area which is 25, 30 million. So we had a hospital. But we had a school. And we looked at the idea of an international school with a British company called British Fortune Group to put the school here, because this gave us the opportunity to link the top and the bottom generations of the hospital, of the family. So Granny would take little Johnny to school in the morning because the middle generation were out at work. And at 3:30 in the afternoon, if Granny didn't turn up, it was little Johnny who shouted out first, "Where's Granny?" So it's this community idea that we wanted to support here. The other thing is we created a street, a wide street, a dementia-friendly street, a street which had the idea that you had big areas for sitting, you had little between trees, you could put market stalls out because the people in China were worried about the chemicals, not yours, the other chemicals that are put on vegetables and so forth. So little market stores are very, very popular because they come from the local villages and so forth. And then there was fairly intense development up at this end, and there was looser development here. There was a small linear park. There was various types of developments, including a proper shopping street, as I say. And the idea is that anybody, whatever age, they could go along and they could either take their computer or sit and watch other people using their computers in coffee shops, tea shops, whatever. And what we had here was we had a central, a front security system, and then around about the middle here, we had what we called a central core system, which was a management system to help to manage the facility management. And facility management is the necessary part of any city to look after the streets, the external parts of the building, and so forth. But then you could add to that internal facilities management. So if people wanted it, you could come in and change their light bulbs for them. Important, because I know for my own sake, my mother fell from a chair trying to mend a light bulb when she was an old lady. So the idea of having somebody to come in and do it is a good idea. To be able to offer them meals, to be able to do all sorts of things, to step up the level of care that they may or may not require. Next slide.
Just 1 minute.
Sorry?
Just about out of time.
Oh, I'm so sorry.
You're enjoying yourself, aren't you?
Sorry. So anyway, this is lifestyle supporting, so I just say, what I've really said is this one, so I'm going to move on to the next slide if I may. This was another one that we developed, which is you have a garden on the roof, you have apartments for the elderly which are sold, but they don't have to be for the elderly, it could be for anybody, and that creates a nursing home area, the shopping area, and then below things like spas as well as car parking and so on. Okay, next one. The spectrum of care, again, I'm not going to go through it, but you can see this is a spectrum of care that's necessary. This is what makes integrated care. It's not just hospitals. Next one. The thing that I just wanted to point out here, NHS England is now saying we have to learn from others, and that means internationally as well. So we can learn from each other, and that's the most important thing. The use of independent living technologies will allow people to live at home and independently. That is what we're all struggling to do and we all want to see. And I use Edward de Bono quite often because I think he's quite a wise man. And he says, if you cannot accurately predict the future, then you must flexibly be prepared to deal with possible futures. The point now about healthcare is it has to be flexible. And how you deliver acute care has to be flexible as well. I think that's my last slide, isn't it?
That is, yes.
I had one that said thank you before, but I forgot to say thank you this time. But thank you so much.